Let me share my screen. And, all right. Can you guys see my screen okay?
Yep, you're all set.
Okay, awesome. Thank you. So, um, like Shayla said, I'm Devyn Woodfield. I'm the data analyst for rehab services at Intermountain Health. And at Intermountain Health, we're a system based out of the Intermountain West. Our footprint covers a lot of Utah, Colorado, Wyoming, Idaho, Nevada, kind of that space. And we are a large system, and our my role is mostly in the rehab space. There's over 200 analysts, data analysts in our system. So a lot of what I'll be going over are rehab specific examples, but the principles I'll be going over apply across all settings. Um, so just a brief history of healthcare data. So let's hop in our way back machine and go back to the ancient world. Healthcare data used to just be on clay tablets, and it was mostly just for the higher class, and problems were fixed by spells and astrology. But then our medical knowledge advanced, and in the Middle Ages, we started compiling these cases, for the interesting ones in the Middle Ages, and then our knowledge advanced in the Age of Enlightenment. We actually started to store admit and discharge information in the late 1700s and the 1800s. There's actually a history of diseases that was compiled from a bunch of physician notes. But then in the 1900s, the medical record came to be mostly on paper. Um, Shout out to my mom, who was a medical transcriptionist back in the day. And we had our first patient identification system implemented. But then in the 1960s, the electronic medical record uh, was it came to be. So Intermountain Healthcare, we became the first hospital system in the US to implement an electronic medical record, or an EMR or EHR is what you'll hear referred to. And it was mostly inpatient. Then later in the 1980s, they expanded to outpatient. And then in the late 1990s, Intermountain develops their enterprise data warehouse, their central repository for all their data. So Intermountain has been this pioneer in using data, building on the foundations that had come before them. And so there's this rich legacy of data at Intermountain. And across the United States, the rise of the electronic medical record is pretty rapid. Only in 2005, only 10% of physicians reported using the electronic medical record. And then in 2011, only 50%, 2019, 90%. I'm sure if we did this survey again, it'd be close to 100%. Um, but in the terms of the grand history of the medical record, the electronic medical record is this relatively new thing that if you learn to wield the power of data, uh, then it can really help you elevate the care that you're providing in your system. So let's talk about that data journey in the electronic record. So data is coming at us from all sorts of places where we got registration, billing, outcomes, you name it. This is by no means a comprehensive list, but we're getting information electronically all over the place. pretty much every click you make, every discrete field selected in the electronic medical record is stored somewhere. So just a review, some of the common EMR products are Epic and Cerner are some of the big players. Intermountain uses Cerner currently, but we'll be switching to Epic here in a year or two. And these EMRs take this data, all these inputs, and normally, especially for hospital systems, all this data is compiled in some sort of central repository. You'll hear it referred to commonly as a data warehouse. And this can either be a local instance or hosted in the cloud. And it varies greatly from system to system. There's a lot of big players out there that operate in this space to host all that's being collected in a healthcare system. And it looks differently. The people supporting this process behind the scenes looks different from system to system. At Intermountain Health, we have an entirely separate team that's dedicated to bringing the data from wherever it is collected or input and bringing it into the data warehouse, what we call the EDW, the Enterprise Data Warehouse. So, and then from there, the data can be visualized. And again, a lot of different tools that can be used. Some of the more common tools are Tableau, Power BI, Looker, Domo, Click. There's a lot more. There's a lot of players in this space. So I just kind of picked some of the more prominent ones you might hear about. And so if you kind of put all this together, this is kind of the journey that it looks like at Intermountain Health. Again, it may look slightly different, but in general, you're going to have your source, you're going to have some sort of repository, and then you're going to have some sort of visualization tool or output tool. And the code we use to kind of extract that out of the database is called SQL, structured query language. So that's the process. And then comes the part of working with data professionals like me, data analysts, business analysts, statisticians. And you might be wondering, this doesn't have much to do with dashboards. Well, a lot of these are kind of bedrock principles that'll help us understand how to develop the best dashboards. So on the screen is some output from a statistical analysis that I did at my very, very first internship for a small startup company. And I literally presented this to the CEO of that small startup to do an analysis on some of our sales and a promotion we were doing. And unsurprisingly, they looked at me just so perplexed. Like, what are we looking at? Like, what does this tell me? Why? And it was hard for me to explain it because this is not a very easy output to read. So it's important to kind of, for data professionals to speak the lingo of clinicians and clinicians to also kind of learn some of the lingo of the analysts so that we can kind of bridge that gap. There's a lot of jargon out there. There's a lot of terms, and some of that terminology is changing. Sometimes it means different things at different organizations. So just remember to communicate. And another call out I mentioned when working with data professionals in your organization is that not all data professionals have that clinical or medical background. My background was in statistics, so I had to learn a lot of the rehab jargon and lingo on the job. I had a coworker that was an elementary school teacher and decided to switch professions. And so she had to learn a lot on the job as well. So typically, data professionals have this more technical background, and need to learn some of this medical terminology on the job. So just tips for communication, always explain the why. Something that might seem really intuitive for you as a medical professional might need a little additional explanation from the analyst. And be specific. The example I always give is, if someone comes and says, "Oh, I need the readmission rate at this hospital," well, you then you got to be more specific. What's 30-day, 60-day, 90-day readmissions to the hospital, readmissions just to the ED. There's additional information that can be given there. So avoid the jargon and the acronyms, especially us data people love our acronyms. Give enough time for the data to be collected, created, and analyzed. It takes longer than you think. And remember that a dashboard development is cyclical, it's iterative. The first draft rarely ever is the final draft. So, and be clear about prioritization. Sometimes we'll get a data analyst, we'll get a request that in your mind is low priority or it's the highest priority, but we don't always know that. So make sure we're clear about that, especially with the way resources work. There's usually way more work than there is time for analytics and dashboard development. So make sure we are always prioritizing that work. So as an example, I had and so now I'm going to weave a lot of examples of dashboards that have been built here. So here's an example of a dashboard. We wanted to look at patient outcomes across multiple settings: hospital, inpatient rehab, home care, outpatient, and looking at their outcomes across all those settings. So on the left was our whiteboard session. On the right was our first draft, which was it resembled our whiteboard, but once they saw it, they were like, that's not exactly what we needed. And so then we went from our first draft, and after several iterations, we landed on a final draft that was a lot more useful for them. So now let's dive in. We know how to work together, data and medical professionals. We have an understanding of the data process. Now we're going to talk about the who, what, when, where, how, and why of data. And some of these might seem trivial, but when we go over this, it'll kind of reveal some questions that maybe we haven't thought about. So who is going to do the data collection? Is the nurse, doctor, therapist, the front desk staff? Is the patient going to be doing the, filling out a survey? On the board, I have an example of our John Hopkins highest level mobility metric. And this was collected by both nurses and therapists. And so there needed to be a constant coordination of, a nurse collect in the morning, a therapist collect in the evening, or what have you. So again, we discuss who is going to collect the data, who is the population of interest. This is especially important when looking at your dashboards. You need to make sure you include or exclude those populations of interest or non-interest to make sure your dashboard is focused on the right population. And you need to discuss the time frame of your data, what period of time are you looking at, and what variables will you use to define that population. If it's something you're not collecting, you won't be able to define that population accurately. So who will be using the data, also important. So this chart here shows the number of times a report was used after it got published. And you'll see this huge spike in activity at the start, but then it just peters off. It kind of tapers off at the end, and not very many people are using it as frequently after that initial go live. So, and this specific dashboard didn't take off because it wasn't really clear who it was for, whether it was for, managers or your frontline clinicians. So you need to make sure, this is who's going to review it, when, and what will be done with it. So what data do you have? What are the variables? How are they defined? What is the metric? And be specific with these questions. When is also very important. What time of the day? When in relation to the visit? This is important for like therapy visits because a lot of the outcomes are collected as the patient's waiting in the waiting room for their visit. Be aware of temporal influences in your data. The graph on the right shows our physical therapy patients in 2020. You'll see that huge dip in the data, which obviously is attributed to the pandemic and when everything shut down. But if you weren't aware of that, then you might erroneously attribute that drop to something else. So you got to kind of be thinking about any potential temporal influences in your data. Another example of when, this is going back to our mobility metric. It was being measured in the day shift and the night shift, supposedly at the same frequency. But when we pulled the data, we realized that our day shift was doing a lot better with documenting mobility than our night shift was. And so because of this insight, we're able to kind of identify, okay, here's what we can do to do better at collecting mobility measurements during the night shift in the future. So where is the data collected? Sometimes you need to know where it's literally physically collected. Like the graph on the right shows our athletic trainers collecting injury data at their various sites. At Intermountain, we have athletic trainers embedded at various high schools, and they're literally collecting the data on the field at the time of the injury. For your setting, you might need to know, is this collected before surgery, after surgery, during the stay, after the stay? And then where is it going to be collected electronically? What form will be used? Where is this stored in the database? What tools will be used to analyze it? So a lot of where questions. So here's an example of where Intermountain has a performance board where all of these metrics are kind of brought together into one place. So this is where they go to digest their key metrics. And so each one of these tiles is a miniature Tableau dashboard that highlights a metric for them. And they can click on any one of these and take a deep dive into that metric if they need more information. So how will it be collected? You got to think about, is this, we're going to collect this on paper or is this going to be collected electronically? Are we doing a random sample or is this more of just a retrospective look at what has been done? What software will you use? Is the data, how is the data going to be stored and aggregated, et cetera, et cetera. So be thinking about these questions, and these slides will be posted so you can review these at your leisure after this presentation. So how will the data be analyzed? So this question alone is going to merit a large amount of attention because it's one of the most important questions. So we're going to take a deep dive into how the data can be analyzed, especially when it comes to diversity, equity, and inclusion. It's really important because there are some pitfalls here that if you fall into one of these pitfalls, then your conclusions will be erroneous. So we've got challenges with data validity. So how the data is recorded. On the bottom right are examples of data points that are real and may be painful to see. So we've got this outcome metric. It's numeric. It's out of 80. And we've got a score and a pain, which is great. But in our next one, this field was not standardized. So someone put 59 out of 80, which the human eye can easily tell, okay, is their score was really 59. They just put it 59 out of 80. So that's okay. We can write in some logic to identify that. Well, then the next person put 60 out of 4, which isn't a valid number. And after investigation, we realized they put the score and that slash, and then the 4 is actually the pain level. Like, oh, okay. They use the score in pain format. Well, this person put a percentage, which does that mean 73 out of 80? Or were they saying that's really 58 out of 80, which is 73%? Not sure. And they didn't collect the pain. This person put a 94, which isn't even a valid score out of 80. And then my person, or so then someone put NR, which I don't even know what that means. Acronym finder didn't really have any good insights for me. But my personal favorite, 785, which is quite the score out of 80. So you need to make sure you put in these valid data inputs so we can have valid data analysis. And again, we need to make sure, and this is more for those that are doing the analysis part, the data needs to be queried correctly. So sometimes it is queried incorrectly. If you need, in this Venn diagram, everything from table A, but not table B, you need to make sure those exclusions are taking place so that you don't get any incorrect conclusions. And it's pretty easy with a simple Venn diagram, but in the medical world, nothing's very simple. Often we've got very complex logic that's like, we need people with condition A, but that have condition, B and C, but not D. And, it's can get complex. So make sure you're querying the data correctly. Another thing is you need to make sure you're documenting things in discrete fields. Free text is great for, looking for the human brain to look at and review, but it's not great for scaling analytics. And maybe one day AI will be pretty good at extracting all these data elements, but right now in the medical world, free text is not your friend when it comes to analytics. It requires a lot more computation or a lot more time for the analyst to extract that information. So now challenges with data accuracy, make sure your data is collected in the same spot, in the same form, make sure it's standardized, because often it's not standardized. Every, maybe a separate hospital or separate clinic will be doing things a little bit differently, and it makes things difficult when the process for collecting the data is not standardized. On the example on the right, we had this test being collected in 2 different spots in the record. So, and we weren't aware of it initially until we started looking at the data. So then we had to go pull it from each spot. Another challenge is when the data is recorded incorrectly. So the number at the top was the data collected by the patient when they filled out the form, but the data on the bottom is what got put into the medical record. And so those numbers aren't the same. So now we have this dilemma of, in this case, it's pretty easy to know which one was the true score. But sometimes when we have this double documentation and it's not in sync, we don't know which number to use, so we have to throw it out. And challenges with current or accurate data. So the picture on the right shows the home address of physical therapy patients at Intermountain. And we've got this huge concentration in the Intermountain West, so those are probably accurate. But I'm betting we're not having patients travel from Alaska for their physical therapy visit. Every one of those patients probably aren't traveling. We probably have an outdated or an incorrect address, which makes an analysis more difficult, especially with equity. we're looking at a lot of socioeconomic variables that are based on where the patient is living. And so we need to make sure we account for that and get that data as current as possible. Now, we also have challenges with accessibility. At Intermountain, we're lucky we've got a lot of resources for getting the data out of the system it lives in and into some sort of visible or accessible format, which isn't always the case at all health systems. Resources are limited. So it might be a challenge to get to the data that's being collected through your medical record or through some third-party application. And so it's just a challenge to be aware of and to lobby for if you need support from upper management to get those resources so you can get to your data. And then with the data itself, make sure we're capturing it at the time of visit. Sometimes, we fail to capture it at registration or at the visit, or, a follow-up survey needs to happen pretty quickly after a visit, or, we say we're going to get some sort of information from the patient at the next visit, but then that patient doesn't come back and we've lost the opportunity. So, Intermountain made a big push to capture the outcome at every visit, which was a huge lift, but then they did. And the graph on the right showed that increase in percentage of episodes that have all the outcomes collected. So, and then variation is a very important one. So this shows each line here is the trajectory of a patient that had the same starting score for therapy, a therapy outcome. And you can see this goes all over the map because there's a large amount of variation. Each patient is different. So how do we quantify that variation? So just be aware that some common aggregations don't accurately describe your data. So on the right, we've got a bunch of X and Y coordinates. We've got, and they have this mean, this average, and standard deviation. Well, this graph also has the same average and standard deviation. And so does this one, and so does this one, so does this one, so does this one, and my personal favorite, this one. So all of those graphs, the star, the oval, our T-Rex here, all of these have the same X and Y average and standard deviation, the same correlation, but these are obviously very different charts. So we're missing information by just taking a simple average. So we need to make sure we're using statistical methods to accurately quantify this information and not just jump to a conclusion based on an average or a total. And again, when you use statistical methodology, you need to make sure you're using correct assumptions. So like this graph shows this study that shows the final grade on the y-axis and the number of hours of studying on the x-axis. So one could jump to the conclusion that the more you study, the worse your grade will be based on this chart, which doesn't really make sense. But once you factor in the course or the type of class, you can see that within each class, the more you study, the better your grade will be. So you need to make sure you're accounting for all the variables, and your friendly local statistician can help you identify what are your important or influential variables and which ones are your confounding variables, the variables that maybe aren't adding much to the response variable. And be aware that correlation does not lead to causation. This is the divorce rate in Maine and the per capita consumption of margarine in the US. That has a 99% correlation, which does not mean that one influences the other. It just means that they followed the same trend, but we can't say one caused the other. And it's the same in the medical world. Why? We'll get to this at the end. So now let's get to the actual building of the dashboard. So we've got these bedrock principles of the data. We have an understanding of it and some of the nuances of working with data and its process. So these are the 6 key principles of building a dashboard that I'm going to highlight. This is not a comprehensive list, but and there's a lot that's been said about this topic. I've skimmed a lot of the literature that's out there, and these are 6 common themes that I've seen across multiple publications about this topic. So we're just going to briefly talk about some of these and look at some examples. So define your target audience. You know, who is going to be consuming this dashboard? So, for example, this dashboard on the right was looking at availability of new patient visits. And initially it was just, a spreadsheet. But the schedulers were like, hey, we look at calendars all day. Can we get this into a calendar format? So because we had our target audience in mind, we were able to build this in a more meaningful way for them so they could see when their next available appointment was available for them to schedule a new patient. Again, going back to our athletic trainers example, here our audience, the coaches and the athletic trainers wanted to see where their injuries were happening. So this way they could see which sports or body parts or injury types were the most common for them to be aware of. Define the question and the problem that you're trying to address. If it's kind of just, I'm just curious what this is, that doesn't get you as far as having a specific question of, what is the question we're trying to answer? In this case, we were trying to answer how far are our patients traveling, or where should we build a new clinic? So we built this dashboard that looks at, what percentage of patients are within a certain mile radius, or what's the average drive time for these patients that are attending this clinic. If we built a clinic here, what would the average drive time be? Questions like that. Keep it simple. So this is a public visualization from Tableau, which looks awesome. It looks like a lot of work. It's looking at the history of Formula One racing, but it's hard for your eyes to focus on what's going on here. It's just so busy that it's almost not actionable because you don't know what to do. It's information overload. But if you keep it simple, then your eye is able to easily identify the trend you're looking at. This looks at our failure rate by visit number. So the more visits you get, the lower your failure rate is in therapy. And this is a trend they're able to easily identify with and to easily see, like, okay, at this point, the patient has started to kind of level off. So additional therapy might not be needed at that point. Again, another key with data visualization is choosing the right visualization. So a lot of times we love our pie charts, and pie charts can be useful. Maybe if you have maybe just 1 or 2 or 3 categories you're looking at. But in this case, what if someone came to you and said, this is looking at failure rates by hospital. What if someone came and said, who has the second highest failure rate? Your eyes have to do a lot of work to find that out. You have to kind of scan the whole pie chart before you can make that conclusion of like, oh, I think it's KD has the second highest failure rate. Where if you just build a simple bar chart, your eyes can pretty quickly identify, okay, here's the second highest and the third and the fourth and the fifth, and here's the lowest. And so your eyes don't have to do as much work. So be thinking about the right visualization. Tell a story with your data. Make it interesting. Make it, eye-popping. in a simple way, building on what we've already talked about, so that you can tell a story. So this shows therapists and their failure rate and the patient's likelihood to recommend. So this is essentially showing how the patient did and how the patient thinks you did together. And it's kind of hard to tell what's going on here, but if we put in a chart like this, so each bubble, each dot here is a therapist. And so you can see in relation to your peers, and the dotted lines are the medians, you can see like, well, I I have a higher failure rate and my patients don't really like they're not likely to recommend me relative to how others have been rating my services. So this is like, bad patient perception and bad patient outcomes, where, some of these other quadrants are more desirable. In the top left is, good patient perception of your services, and the patient actually didn't make significant improvement according to their outcomes. So this is more insightful from a visualization perspective, because you as a therapist, and this is done in our system, you can come in and see where you fall among your peers, according to these metrics. So allow for data exploration. This, is a dashboard. There's a lot of metrics going on here, but, let's look at this one specifically. There's this huge spike in red on this metric. And you might, as an end user of this dashboard, want to know, well, what happened here? You need to make sure that you enable this ability to take a deeper dive on any one of these metrics to identify the why of why a metric might look good or bad. Because it could be because of a mistake in the analysis, or it could be because of some unknown or new trend that started. You need to be aware of that. But it's only going to be possible if you're able to kind of explore the data and kind of get your hands on what's driving these charts. So these are the principles. Define your target audience, define the question, keep it simple, choose the right visualization, tell a story with your data, and allow for this exploration of your data. So I'm going to close with a few examples of some other dashboards that highlight some of these principles. And you'll notice on a lot of these, like this is our acute ICU patients year over year. A lot of my dashboards are nothing fancy. It's, summary metrics, numbers along the top, line charts, bar charts, with some filters on the right, that helps them see their numbers. We've got readmission rates for our patients that do and do not receive therapy, which hospitals have the highest and lowest readmission rates. We've got, here's an example of a dashboard that tells a story of, the patients that are more mobile, and that's the number along the bottom. Those patients are more likely to be sent home from the hospital or to home with home health services. And so, we want to make sure for those that are more mobile, that we are pushing them towards that more appropriate care setting. And for those that are really not very mobile when they're discharged, that might be more likely to send them to a SNF or long-term care facility where they might need that extra care. Here's the more equity-focused dashboard, where we're looking at percentage of our non-English speaking population that were being offered interpretation services. And so we can see, how we're doing there by facility and trended over time. And, we're trying to expand our services to those communities that might not be able to access physical therapy by launching this virtual physical therapy option. And so that's what this dashboard represents, is, how many patients are we seeing, and are they coming back to the ED or our urgent care facilities anyway, or are we helping them avoid that by offering this virtual physical therapy option? And then this, I think, will be applicable to this group is our equity dashboard. So this dashboard has a bunch of filters at the top, and then the green box in the middle allows you to choose your variables and your metrics that you want to look at. And so essentially, this dashboard was designed to just explore the relationships of certain variables and certain metrics for certain populations. So you use the top to filter to your population of interest, and using demographics, location, encounter, diagnosis filters, and you can look at certain equity variables and metrics and how those relate to each other. And so this has been a great tool for clinicians to just go in and explore. And fortunately or unfortunately, I guess it's fortunate, we spent a lot of time and we weren't finding any like huge disparities with this by using this dashboard. And so I'm jumping ahead. And so this kind of zooms in on some of those filtering options. So you got all these equity metrics that you can use to filter on, to help you identify the population you're looking for. And there's so many variables. These are all the variables that you can look at. Here's all the metrics you can look at. And so you can look at up to 3 variables at a time. So there's literally 3 million possible combinations of variables and metrics that you can look at, which, that's where you might need to get more involved with a statistical analysis to help you identify which variables and metrics you need to be looking at. So now what we weren't finding a lot of huge disparities here or significant disparities. So we shifted and thought, well, maybe these are all patients that have received care. We thought maybe there's more of a problem with access, for those that should have gotten care but were unable to for whatever reason. And we found more of a trend there, looking at their area deprivation index, this measure of there's a bunch of socioeconomic variables where one is kind of they're kind of most deprived according to this ADI number, and 5 is kind of least deprived. And we found, or sorry, 5 is most deprived, 1 is least deprived. So we found that those that have come from more of those affluent neighborhoods were more likely to attend their therapy versus those that come from more of the least affluent neighborhoods, and they were less likely to attend therapy. So we have identified this one, and it's one we're currently looking into, of how do we make sure that where these patients live does not dictate whether they can or cannot get the therapy they need. So that's something we're currently exploring. In this presentation, I've tried to touch on a lot of different dashboards. We've got well over 100 at Intermountain. Here's a list of all of them. Don't worry, you won't be quizzed at the end, but analytics is so powerful and is helping a lot of different areas in just rehab to do what they need to do. And there's people like me that are doing the same thing in all the other areas at Intermountain, and a lot of people like me doing all of these same things at systems across the United States. So now I'm going to get to the why. At Intermountain, our mission is helping people live the healthiest lives possible. And why I do what I do is I like using the data to help improve the quality and the equity of the care that we're providing. I've got three kids, and they've had some health problems. These are one of them had UTIs all the time, bladder reflux. Another one had that same one had periodic fever syndrome. I had a child born with nevus sebaceous, so it's a bald spot on the head. And all of this was able to be resolved through some medical interventions and through some specialists at our children's hospital. And a lot of the care they received was informed by dashboards and analytics and numbers and monitoring the metrics to know what and when to do. And so that's empowering and motivating for me, is because of the data and the dashboards, the care we're able to provide is able to help everyone live the healthiest life possible, including my kids, who now, you wouldn't even know it, are living their healthiest lives. So that's all I have for now. I'll pause here for any questions or comments from the group.
Let me see if we have any questions so far. Well, I have a question. I'll just kick it off. So you mentioned challenges with data validity, accuracy, and accessibility. And I kind of wanted to know, what advice would you give institutions who are just realizing or coming to grips with the benefits of data visualization, but who are needing to get the institutional buy-in from leadership and other stakeholders to successfully implement a project? Like, what advice would you give, and how did you start as well?
Good question. I would say make the case to invest in those resources that will make the data accessible to you. So if you don't have a team of analysts, or a analyst for that matter, what I've seen a lot of systems do is they will have some clinician be the pseudo analyst for a time. They'll collect the data. Sometimes it's just on paper, and with that data they'll improve some sort of process, or avoid some cost or what have you. They'll use that data to provide a benefit, and that's what you can take to leadership and upper management to say, hey, look, we did this with like a really simple, rudimentary way of collecting and analyzing the data, and look at the benefit. If we invest in hiring an analyst, or invest in purchasing this tool, or expanding a current tool to help us leverage this data in a more dynamic way, this is the benefit that we'll be able to see, using your simple use case as an example. And that's what can, if upper management isn't on board, that can help push the decision makers towards thinking about, like, okay, it is an investment, because analytics, I produce zero revenue technically. I'm not seeing patients, but because of the efficiencies I'm creating and the costs we're avoiding, an analytics as a service will provide that value to the organization. Does that help answer your question?
Definitely. Thank you so much, Devyn. Let me just check to see if there are any more questions from the audience. And if not, we would just want to say thank you so much for joining us, and thank everyone for taking the time to join us in today's session. If you're joining us for the first time, we want to invite you to visit our DEIJ toolkit. Annie's going to put the web address in the chat, but visit our toolkit so that you can see all the other webinars that we've posted over the last couple of months. And if that is it, I would like to say thank you again, and thank you, Devyn, for joining us. And let me see if we have one more question. Okay, Annie's put that in the chat. Thank you so much for joining us. Oh, Dawn has a question. Go ahead, Dawn. Go ahead, Don.
And there is a question in the Q&A, Shayla.
Oh, thank you so much. So we have Catherine who's asking, are there websites where people can look and share information about building dashboards?
There are many. I mostly know Tableau. That's the tool I've learned on, but there there's it sounds pretty simple, but it's free. There's a lot of YouTube tutorials out there. There's Tableau offers a lot of resources, but ones that come to mind, there's yeah, I don't have any specific websites that come to mind, but whenever I'm in a bind on how do I build this or how do I get started, I'm usually just Googling and finding those resources that way. So nothing nothing too academic in that space, but I can send some additional resources after I look into it if you'd like.
Okay, thank you so much. Oh, Dawn says she doesn't have a question. Okay, before we wrap up, any more opportunities for questions? Looking at the Q&A session, there's nothing. Oh, we have one more. Okay, where can people find you? Where is a community of data scientists who have the capability to build a dashboard?
So that's a good question. Um, there's there so there there's a kind of a there is a community of data analysts, um, and there's um, so oftentimes if you're like looking to hire one, you'll just need to make sure that the job posting is robust enough to kind of flag the attention because an analyst can be called a lot of different things in different systems. There's data analyst, business analyst, data scientist, business intelligence. There's a lot of different terms that can be used. So if you're searching, make your job posting. If you're just trying to like connect with someone, LinkedIn um, is a good way to kind of find a lot of those networks of data analysts. And there is Intermountain Analysts founded an organization called HDAA, I think, the Healthcare Data Analytics something. So there's, and they have a conference yearly. It's kind of small, but it is analysts in the healthcare industry that get together. So there's a lot of networking opportunities for that organization. I can look up that information and send it along afterwards as well.
Thank you so much. We have time for one more question. Anyone has it? Okay, well, thank you so much for joining us, Devyn, and we'll be sure to put your information on our toolkit and you can find the information there.
Awesome. Thank you so much.
Have a great day, everyone.